Welcome to the Afiya Spine and Pain Institute. This is our little office where we do really great pain procedures for patients and hopefully give their lives back. So we have two trainees with us today. So Dr. Ali Rizvi.
Hi, how are you guys?
He's an emerged doctor who's doing a fellowship in chronic pain. And we have a soon-to-be pain trainee,
Hopefully.
Dr. Monty.
Just at the end of my 4th year physiatry right now and hoping to start 5th year physiatry and then apply to pain.
And these two gentlemen were working with me today in our center today, getting patients better, doing procedures, getting a pain management plan for them. And I'm very, very happy to have them join the ever so growing chronic pain community. So why do you want to do chronic pain?
Honestly, so I grew up with a mom who had a lot of chronic pain, and it just always felt to me like, why can no one help her? Like, she's got all these doctor's appointments, she's going to clinics over and over again, and nothing's changing over years, over decades. So for me, I felt like this just can't be it. Like, there just has to be some doctors out there that know how to treat chronic pain. And after I got into physical medicine rehab, I was a first-year resident. And I started to meet some, physiatrists who'd gone into do this other fellowship known as pain. Started to work with them, found my way here in this clinic, and honestly, it's an honor to be here. I think what's done here is not done in many places in the country at all.
So,
I think there's provinces that don't have clinics like this.
So do you notice a difference between people or physicians who are chronic pain trained with an official fellowship as opposed to ones who are not?
Yeah, I think there's absolutely no comparison. I think it opens the door to doing some procedures that are extremely difficult and procedures that sound very dangerous on paper and would definitely be very dangerous if you didn't know how to do them correctly, if you don't do them with the proper equipment like x-rays, ultrasound. Dr. Pirani, as you know, I actually flew my mom out here to Ontario to get her pain treated because no one in Alberta was able to give the treatment that she needed at the time.
Here with Dr. Rizvi, our chronic pain fellow here. So his background is emergency medicine, and then he's made the transition to do an intense training program in chronic pain. So what's the difference, like the day-to-day difference between being in the emerge every day and chronic pain? That's a pretty big jump and a different type of population. How is it similar and how is it different?
You know what? That's such a great question. I think the similarities are the fast-paced environment, wanting the patients to be seen in an appropriately timely manner, rather than them having waited maybe months to years to have their pain treated. I think the differences nowadays, especially comparing the emergency department to now pain, is really focusing on patient quality of life. And the work we do here with epidurals and pain management, be that through RFAs or otherwise, we really improve patient health span and quality of life. And that's such a drastic difference from a lot of fields in medicine where we're kind of just focusing on pushing patients along and keeping them alive, but not really improving their quality of life. So for me, I think what really helps and makes pain medicine worthwhile for me is I get to do a procedure on a patient, be that a bad knee, a bad hip, a bad low back with sacroiliac pain, and I get to see them walk out with a smile and actually go back and doing the things that they want to be doing. An 80-year-old man hiking, or a 65-year-old woman going back and training for a marathon, and all those things to me are immensely rewarding.
That's one of the reasons why I love chronic pain too, is just seeing people get better. Yeah. But really, we need to create awareness for the right type of chronic pain management, right? And so we want to see people get better. We want to see long-term benefits. We want to see, there's more than just injections that we do here. So medication management, we run pain classes here. There's a very, very great evidence for patients with the mental aspect of pain, right? So the psychological aspect of pain, and we try to harbor classes here for patients that we can really see patients from a holistic perspective. And so, what do you think? Like, you've been training with us for a little while. What do you think the best, the most, the greatest advances in chronic pain are?
Greatest advances in chronic pain are, I think being able to treat radiculopathy or low back pain without a surgical intervention is something that I hadn't even thought about from the emergency perspective. So for me to be able to see patients get better with minimally invasive treatments without having to go through spine surgery and months of rehabilitation, for me, I think those are great advances in pain medicine, but also just seeing new techniques develop, be that RFA, pulse radiofrequency of nerves that have been causing chronic pain, and really getting to the nitty gritty of solving that cyclical pain cycle is fascinating to me, and I think is what's drawn me to this field.
So what about how many chronic pain patients would you see on a general shift when you're in the emerge?
What an excellent question. I don't think you can go through a single shift in the emergency department without like 50 to 60% of your patients having some sort of chronic pain pathology, be that a shoulder or rotator cuff sprain that they've had for years, or back pain or low back pain. Like, I can go through a shift and I have 5 patients with chronic radiculopathy or sacroiliac low back pain that, unfortunately, in the emergency setting, there's not much for me to do. And thankfully, I have places like this that I can refer out to, that patients who had been suffering for 5 years have at least an answer and a plan moving forward that hopefully can get them better within months. So that's what's nice.
So one of the things that I love about chronic pain and things that I've seen for the future is that historically, there's very few specialties doing chronic pain. Yeah. But now we realize that so many people can contribute to chronic pain. Chronic pain is so complex, wouldn't you agree? So we have physical rehab medicine, we have anesthesiologists, neurologists, surgeons getting involved with chronic pain, but we really want to deliver chronic pain in the right way with properly fellowship trained people who are actually using image guidance and using the best technology and actually investing in patients, because you're really investing in making their life better. Yeah. What's the technological advances, the differences that you see in pain? You said you flew your mom out to see me.
Yeah.
All the way from Alberta because you couldn't get access to care. So I think access is a big point in chronic pain. But getting the right procedures and the proper diagnoses and the proper aftercare for procedures is really, really something that I'm very passionate about. Mm-hmm. And so what are some of these technological advances in chronic pain that you think give patients long-term benefit?
Yeah, so I agree, multimodal management, medication, rehab. I mean, I'm a rehab doc, so my main thing is rehab. But then there comes a time where you need interventions, and the interventions that were being offered to my mom for, radicular pain was you either get a steroid injection or you get a surgery. And there wasn't a lot of this new tool, this new technology that's come out in the last while, radiofrequency. And so may I show off this machine, if that's okay? So this puppy can do some pretty cool things. So if you hook up this probe, and this probe goes all the way into a needle, now we can start using electricity to deliver medical care. So instead of just constantly putting cortisone, we know how it might degrade joints, we know that it might spike blood sugars in patients with diabetes, and who has neuropathy more than patients with diabetes, right? So you want to find tools that are going to reduce side effects. You want longer lasting treatments. And frankly, this has not been around for very long, perhaps, and that's why it's maybe just being adopted more so here in Ontario than Alberta. I'm not really sure, but there was never an opportunity for her to get a treatment with this kind of technology. So
another thing that I've always noticed is, we always tell our patients, oh, you need to exercise, you need to lose weight, you need to do this. But it hurts. But how can you get them to do these things if they can't move, right? And so, or we give them medications only, and we see, okay, well, you're on these medications, however, you're just getting side effects from the medications. Yeah. We need to get our patients moving, and I really believe in kind of the 4 Ps of pain management, and that's starting with the brain, psychology, pharmacological interventions, physiotherapy and movement, and then lastly we do procedures, right? And so that's the way at Afiya we want to practice pain management. We want to give patients hope that that we can get them moving again, we can get them back to work, and that's something that I think all the physicians that have joined us are all passionate about. So that's it, right?
Definitely. From my experience, we do the spinal cord rehab board, stroke rehab board, at the end of the day, like the main thing that's going to help this patient, and I know, is going to be the rehab and the physiotherapy. But I'm not the physiotherapist, so what's my role on the ward, right? So my role on the ward as the physiatrist is to find and remove obstacles that prevent the patient from engaging fully in the rehab that they need so that they get really good long-term outcomes, right? So if the patient has too much pain, if the pain is affecting the patient's sleep and the patient can't wake up and do their 9 a.m. physio appointment, these are all barriers that we have to start tackling. And I think procedures are just one tool in the box, but at the same time, there's procedures and there's procedures. And I think that that's one of the things that we should also discuss.
So Dr. Rizvi, we've loved having you as our fellow. I've definitely seen you learn a lot and improve and really take good care of patients from a holistic approach and as well as including the procedures. So, the jump from emerge to interventional pain and pain management in general, different scope of skills, different set of skills. Have you found you've changed your approach in the emergency department, learning what you have in the last 6 months with us?
Absolutely. I think, like I said earlier, about 40% of my patients or 50% of my patients have some sort of chronic pain. And I'm using all the skills that I've learned here, be that from a medical management perspective, knowing what medications to use for neuropathic pain, not just giving everyone opioids as a result of some sort of illness, right?
Yeah.
They have radiculopathy pain, and then typically before I didn't know what to do, and I would just send them with some pain meds so that they could get through the next few days before the next urgent referral could have been seen. But now I start them on pregabalin, or I try to manage their neuropathic pain. The second thing I think that's helped is learning these procedures and learning how to be good with ultrasound for peripheral joints, or something as simple as migraine headaches. Now I do blocks for them, and my patients are not waiting for 30 minutes for medications to kick in. Rather, I'm doing a quick block that it takes about 5 minutes, and they're better, they're happy, they walk out, and they have more synergistic, long-lasting relief rather than just a one-time pain medication through the IV and they're good. Other things, be that sacroiliac joint pain, I can quickly do an ultrasound and try to inject that. I also use the skills for nerve blocks so that if I have a big laceration in a certain part of the body, the foot, the arm, the hands, now I know, okay, I can do the radial nerve block, I can do the ulnar medial nerve block, I can try finding ways to alleviate pain so that I can actually help my patients in the emergency department better. So I don't know if that's a succinct answer. It's not everything, but I think I've been using a lot of those skills.
No, yeah, excellent answer. And then that's what's really important. And that's what I was alluding to, is that we know that there's so many people with chronic pain. Like 1 in 5 Canadians have chronic pain, and there's just not enough well-trained chronic pain physicians to actually take care of everyone. So the fact that you're training with us, I think, is also beneficial to the emergency department that you work in, because you can teach them some of the skills so that we can better treat patients, and then we can also get them to the right places where they can get, holistic care and get them back to, the things that they love, whether even just getting back to work, going to the grocery store. Some patients are like bedridden, right? And so it's really amazing that I've seen in my practice is that pain doesn't have any prejudice. It affects anyone, right? It affects anyone, rich, poor, doesn't matter what your color is, doesn't matter what your ethnicity is, doesn't matter what kind of background you grew up in. It can affect anyone. So it's really something I've seen in some of my patients where one accident, one injury, one change in their life has actually caused them to have chronic pain. And so really, I think a thing that we're talking about is when you see someone in the emergency with an acute radiculopathy, right, is we really want to stop that acute pain from becoming chronic. And historically, if it wasn't a surgical indication, it was all the conservative measures and things like that. However, an image-guided procedure, now you know what medication to start them on, a non-opioid medication that actually can calm their nerves down, right? Get them into physio, get them into rehab, which is a very important component. But really, we are chronic pain physicians, but we also want to stop that acute pain in becoming chronic. Because when it becomes chronic, it actually has, long-lasting implications to society as well. Not
It's expensive.
it's expensive. It's
and-
costly. Yeah.
And I think going back to my earlier point about our goal being trying to improve quality of life and health span,
Yeah.
and by catching these acute patients like you're talking about in the earlier phase, being able to refer them to a rapid access clinic like this, getting the medication in the right spot or starting them on the appropriate stuff, we can really improve quality of life of people and get them, like you said, active and back to rehab and doing the physiotherapy that we tell people to do, right? So
Yeah.
I agree with all the above.
Yeah. I agree.